Hello, everyone. We will go ahead and get started with our first session for today. Welcome back to our SRAE TTA virtual topical training. Track 2, today's Understanding the Optimal Health Model in the Context of SRAE. My name is Megan Yarber from Public Strategies, and I'll be the host for today's session. Before we get started, I'd like to review a couple of housekeeping items with you. You may have noticed that you have been muted upon entry. We invite you to use the chat box to ask any questions, make any comments, or address any technical issues you may be having. When you're replying in the chat box, please be sure to select the drop-down to everyone option so that the moderator and presenters can read your questions. If you do not see the chat box located in the panels on your screen, please select the chat icon button at the bottom of your Zoom window. The controls will auto-hide, so you may have to mouse over to the bottom of your screen to display the toolbar. As a reminder, this presentation will be recorded. Recordings, presentations, and handouts will be available on the exchange after the topical training has concluded. At this time, I would like to welcome today's moderator, Mary Ann Mozak, President and CEO of Ascend.
Well, hello, everyone. Welcome to day 2. This is another exciting presentation, and I know that you're going to have a lot of very valuable information today from this session, Understanding the Optimal Health Model in the Context of SRAE. And just a little bit of housekeeping, we want to make sure that, if through the presentation you have some questions, be sure to put those in the chat, and we'll do our very best to monitor those and answer for you. So without further ado, it's really my pleasure to introduce Dr. Diane Foley, who is currently the Acting Principal Deputy Assistant Secretary for Health, Deputy Assistant Secretary for Population Affairs in the Office of the Assistant Secretary for Health in the U.S. Department of Health and Human Services. So with that, we will begin this very valuable presentation. Dr. Foley?
Thank you, everyone. And greetings from Washington, D.C. This would be, I know, a lot more fun if we could be in a face-to-face setting, but again, I am so impressed with the technology that we have all learned over the last several months and the ability to really engage with a large group of people through this avenue. And so I'm excited about being here to talk with you a little bit about the optimal health model in the context of sexual risk avoidance education. And again, I'm going to digress just for a minute because it's interesting to me to think back of this full circle that I have come. I was once one of you many years ago. I directed a program in Colorado, and my first really foray into this aspect of federal funding for sex education came in the form of a grantee. And throughout the course of that was involved with consulting with a lot of different groups across the country, and then ultimately I'm here in this position. So again, it's a little bit surreal in some ways to see this, but I'm excited because it's very gratifying to see so many of you continuing to do this work that we know is so important for the adolescents in your communities. And so again, I know that you all are very, this is part of what you do every day. And so again, this presentation is going to somewhat be a review for you, but I'm hoping that I will bring up some additional points that will help you, and primarily to help you as you have this conversation with those around you, as you're trying to explain why this is such an important part of what you are teaching. And when we think about the whole idea of, there we go, okay. When we think about looking at optimal health, we really think about the message and the vision of the different organizations that are involved here. All of us are part of the Department of Health and Human Services, and the mission statement is to enhance and protect the health and well-being of all Americans. When you look at Administration for Children and Families, again, promote the economic and social well-being of children, families, individuals, and communities. And so again, we're all working together towards the goal. And I would argue that optimal health is the basis and the foundation for all of this. When we talk about public health, again, in a general sense, the whole purpose of public health is to promote health. Part of that, as you promote health, you are going to prevent disease. But this, again, is a population message, and you are focusing on looking at changes in unhealthy behavior across a large group of people. So you're focused on groups of people or communities, not as much individuals. My argument, though, is that the same public health principles that you use to talk to the population work individually as well. And again, that's where I think the optimal health model comes in, and I'll show that to you in just a moment. Again, public health prevention is not a new concept. In the early 18th century, Benjamin Franklin, ounce of prevention worth a pound of cure. Again, even earlier than that, prevention is better than cure. And so again, it's something that we have as public health professionals have been accustomed to. And it isn't until recently that that particular approach has been applied, particularly when we talk about sexual behavior. It seems that it has been something that has been difficult for people to accept that this truly is, we have to address it in this way. Optimal health, again, I know you had a long discussion about this yesterday and an excellent presentation by Valerie Huber, and so I'm not going to belabor this point, but just to review the fact that we're looking at a holistic approach to this, and that there are a number of factors that work into this. And the bottom line, though, is that you're opening access to environments that make positive health practice the easiest choice. The idea that moving towards promoting health is the aspect that we're looking at. And this becomes easier when we're talking about adolescents because they don't have as many bad habits to change. When you get as old as I am, talking sometimes about promoting health, there are a lot of habits that I've developed over time that may be more difficult to change. So we have an opportunity at the very beginning to help establish patterns of health, decisions around health making that are going to make a lot of difference in the long run. In this public health space, we're talking about not just physical health, but emotional, social, spiritual, and intellectual health. But the important part about this is sometimes public health officials can be seen as somewhat uncaring or not focusing on the individual person because they're looking at a population-wide message. And I would argue that that is what helps make this so important because yes, there's a public health message, but it has to be put within the compassion of recognizing where every single person you're talking to, where they are, and focusing on helping them move to a place of better health for them. So you're focusing on health equity for every segment of the population and doing that in a compassionate way. When you think about the decisions we make every day as public health professionals, one of the questions we're constantly faced with, this is a problem. We have to determine what is that problem, but before we can really address the problem, we have to determine what the cause is. What is the risk factor? How do we identify what it is we need to look at before we can really address this problem? And then once we've determined the risk factor, then we go about deciding about our intervention. And this is where the optimal health model comes in. It fits in the intervention piece. It's how we develop our approach, how we develop our programs to address whatever risk factor it is that we've identified. And this last step is probably the most important one. And again, that is, once this is implemented, we have to evaluate it. How did it work? What didn't work? How did this particular approach not work for this segment of the people we were talking to? Start all over again back at the beginning. And we cannot forget that last piece or else we're not growing and changing. When you look at the optimal health model, as I know was presented to you yesterday, we're looking at this in layers of risk. And our goal is you measure success by how close you can get to a no-risk state. Or saying that another way, moving away from higher risk. If you're going to put that in the typical clinical or public health terms, we look at this in primary prevention, or these are practices or programs that avoid the risk. You prevent the exposure to the disease or the onset at the high risk or onset of any high risk behavior. You're trying to primarily prevent something before it starts. Then there's always the secondary prevention or intervention where you reduce the risk. Yes, the behavior is there, but how can we reduce the consequences of whatever this illness is or whatever the high-risk behavior is? And then lastly, there's the treatment option where you're treating that illness or consequence of that. One of the things that has been such a challenge to me since working here at the in the office of the Secretary for Health is he has challenged us to change the way we look at every program that we have to make sure that we're not just a sick care system, but that we truly are promoting health. That we don't focus on treating the issue or the problem that has occurred, but we look before that to determine how can we prevent people from even getting to that position. And again, this model fits beautifully into that. So when we're talking about this, how does the optimal health model inform our programs? Again, the whole purpose of why we're talking together this afternoon. And I would say that it is the foundation of these programs. And I want to show that to you in a couple of different ways. We know that primary prevention, avoiding risk, is the optimal way to have good health. The health outcomes are generally improved when behavior risks are avoided during adolescence. The other thing that is critical about this, and this is why I love working with groups like you, because for the most part, if you're doing this work, you like adolescence. You enjoy this age group. I would say that you cannot be effective unless you do. And again, it's a fascinating age group, but I believe wholeheartedly that adolescents are capable to develop skills that will allow them to avoid risky behavior that leads them to optimal health. I think that many times adults sell them short and make the assumption, you know, they're not going to do that, so this is the way we need to approach it. And I would say that is disrespectful to them. That they, once they are explained, once they understand what their risks are, they are more than capable of developing skills that are necessary to avoid this. Now you notice there are some important statements here. They have to develop the skills, and in order to develop skills, they need to be taught skills. And again, very, very important piece of this as we move forward. Now, I think that historically, where we have been is that we tend to look at this almost in a binary way. We look at this group of adolescents that we are talking to, and we put them in groups. They are either choosing not to have sex, and for the kids who are not having sex, it's primary prevention, and then there are those that have sex, and they're already having sex, and so there's another approach. So it's a two-pronged approach. And I would argue that it is much more complicated than that. I would argue that at any point in time, there is a continuum of change. And we have significant research around approaches that are primary prevention, approaches that are tertiary intervention. We don't have a lot of research of this middle ground, and I would venture to say that many adolescents live in this middle ground. There's a continuum of change. And the secondary prevention needs to find these youth, their desire, we define it by they desire to take a time out from sex and maybe reestablish new sexual boundaries. How can we help them get there? How can we help them be in that situation? And again, at any point in time, they can be anywhere along the spectrum. Critical that we develop interventions that are based on the readiness to change in our audience. And again, sometimes that is hard when you're talking to large groups, but I think that what we are finding as we look at the research here at Health and Human Services is that there is not a one-size-fits-all type of approach to this. There are core pieces that are important and that will work for different groups of individuals depending on where they are. And what we are working on, a lot of our research right now, is all surrounding this core component piece to see what are the components that are the most important to determine and get the behavior change that we're looking for in order to lead these adolescents to optimal health. You all are familiar, I think, with the stages of change theory. There's all kinds of things around this, but I'm going to review it briefly. This theory has been well tested across many different disciplines, but basically, in order to see behavior change around anything, you go through a number of stages. And the first stage is pre-contemplation. You're either unaware of or you underestimate what problem this behavior has and you have no serious intention of changing it. So this is a pre-contemplation stage about a number of different behaviors. The next stage is contemplation. And that's where you begin to become aware there might be a problem here, and you start to think about maybe changing your behavior. Then the next step is preparation, and that's where you really develop this intention to change, and you give this a specific time frame. Maybe I'm going to do this next week. It usually happens right around Christmas and New Year's, where you have your goal for New Year's, right? I'm making a plan, in this amount of time, I'm going to change my behavior one way or the other. You've engaged in some kind of action to achieve change, but you've not yet risked that goal. You've not reached it yet. Preparation and action are very closely together. The action is you've committed to change and you've actually been successful, but your success lasts anywhere between 1 day up to 6 months. With the increased danger around that time of slipping back into whatever stage you were before. And then lastly, it's maintenance. And this one's defined as this behavior change is there and it's been sustained for more than 6 months. And so again, as we think about these changes theory, it's so important to try to determine where adolescents are as you're having this conversation with them. Now, again, there's a health belief model that can help us a little bit determine what are the factors at each of these movements, from contemplation to preparation, from preparation to action. What is it that we as educators need to put into these spaces in order to help move in the direction we want them to go? So when we're talking about the contemplation to preparation, there needs to be a motivation there. There needs to be an opportunity, and they need to feel like that there's an ability to change. This is where all of our talks around what are the benefits, what is the motivation to you to make this change. All of us know that behavior change is not easy. And many times the harder the change is, the more motivation there needs to be there to make that change. This happens across the whole wide range of behaviors. When you're talking about going from preparation to action, there are so many things that can be barriers or that can actually help to achieve that change. What are the barriers that are there for me making this change? What are some cues I have to action? How good do I feel about myself that I can actually do this? Then what are the downsides to this? How hard is it going to be for me to do this? What are some benefits there? So all of these things need to be woven into our presentations as we are trying to look at this change in behavior. I think one of the first steps is when we define sexual risk cessation, it's choosing to discontinue sexual activity after having engaged in it. So this is the group of kids that you're talking to. They've already had sex, but they're thinking about maybe they don't want to start that back up right now. Okay, now we know that's true. Those of you who follow the youth behavior risk surveys along the way know that the percentage of adolescents that say they have had sex at least one time is higher than the group that says they've had it recently in the last 3 months, right? That's a group of kids in there that are in this stage, in this phase. So accepting that as a viable option, accepting it as a question that you can ask, and I'm going to bring up a specific question a little bit later in this talk that we can use to help us determine we've accepted that this is a possibility and help our clients, our people that we're talking to, work through this in that way. I think secondly, there need to be skills around helping set healthy boundaries. Sometimes there need to be a discussion around what is a healthy boundary. Maybe if this group of adolescents that you're working with has not seen healthy boundaries, certainly they aren't receiving healthy boundary messages from the media around us. And if they aren't receiving that at school with their peers at home, this may be very difficult. They need skills on how to communicate the decision to stop having sex. And most importantly, and all of you know this, is that there's peer support in this decision, how important that is to them going on from the preparation to the action to the maintenance steps. Again, there's a belief in tension. What we see then as outcomes from this is that there's a decrease in the number of sexual partners, decrease in the frequency of sexual activities, and ultimately long-term, when we look at this, the ultimate goal in this would be that we see a decrease in the sexually transmitted infections and teen pregnancy rates, which is what the intended goal all along of these programs. But if we only focus on the end goal of, let's say, decreasing teen pregnancy, and again, I think that the terminology that we use, adolescent pregnancy prevention or teen pregnancy prevention or some of these things, those are embedded historically based on legal and statutory requirements in the law. But I think that is focusing on a sick care system. And I would argue that over the years, we have done a very good job of helping to prevent teen pregnancy. We have seen that drop. We have a long way to go. I'm not arguing that. But what has happened as a result of that is that we have an unintended consequence of a sexually transmitted infection epidemic in adolescents. Because if you think about the messages for sexually active teens, typically they revolve around using some form of contraception, and we have gotten very good at preventing pregnancy. But none of our best methods that prevent pregnancy have any effect when it comes to sexually transmitted infections. And so we're seeing the consequences of that. And that is why I would argue again that implementing an optimal health model into this, where we're looking at going to the lowest level of risk that you have, that you can find for yourself, is indeed optimal health. And that's the message that we're trying to portray. So when we look at what it is that we're called to do, what we've been funded to do in this situation, the public health issue that we're talking about here is teen pregnancy primarily, but I would throw in that it's also sexually transmitted infection and disease. If we are not addressing both of those, we are missing the point here. And there have been some significant changes in the way that funding announcements are put out and the way that awards are given based on the fact that requirements are in there that you have to address both of these. The good news around this is if you use an optimal health model in your program, you're addressing both of them. That is the answer to this situation. The risk factor that is identified many times in this situation is unprotected sex. That seems to be, this is the risk factor for teen pregnancy and sexually transmitted infections. But I'm going to challenge that just a moment. Because if you're talking about protected sex, okay, does that really lead you to no risk? If you have sex that is protected and consensual, is it truly no risk? Evaluate that just a minute. Protected sex for pregnancy. Again, hormonal contraception we know about. For the most part, about a 98% protection against pregnancy, depending on which type you use and how consistently you use it, but really pretty good. With condoms, again, typical use condoms for pregnancy, they work pretty well. This is not listed in percentages. The way that this is defined is out of 100 couples who use a condom every time they have sex to keep from getting pregnant, at the end of a year, 13 out of those 100 couples will be pregnant. So that's the way risk is determined, or typical use, success rate of condoms are used for pregnancy. Well, let's talk about sexually transmitted infections. Okay, if we're focusing on pregnancy and we have that as part of our curriculum, again, it's important to understand that. It's important to incorporate that information. But what we know is that there is no protection against sexually transmitted infections or diseases with hormonal contraception. None at all. We also know that the more often, there's a number of studies, and I have those listed there at the bottom of the slide. And again, I think these slides are going to be available for all of you. But what we know is that the more effective form of contraception that is used, the least likely there is to be dual protection or the use of condoms as well. And 1 out of 5 females, 1 out of 6 males reported the use of condoms with their last sexual encounter if their partner was on some form of hormonal contraception. In the last 3 months, 17% of pill users and only 1.8% of LARC users reported condom use with their last sexual encounter. So again, significant issue when we're talking about sexually transmitted infections. And I know that these issues are more complex than that. A lot of it depends on how long you've been with that partner. If you're in a marriage situation and you're using this simply to keep from getting pregnant, and you're with your partner and you trust your partner, it probably isn't a need to use condoms with every encounter. Okay, there's a number of different nuances that are important, but when the typical approach to this, when someone comes into a family planning clinic or something and wants protection because they're sexually active, they may have multiple partners. The issue is pregnancy cannot be the only thing we think about when we're talking about an optimal health approach. Here's what the CDC talks to us about protected sex. And again, this probably is information that many of you know, but I just want to review it carefully because it's so important that we are accurate when we're having conversations with adolescents about this. The latex condoms, when used consistently and correctly, are highly effective in preventing the sexual transmission of HIV, which is the virus that causes AIDS. They go on to say they reduce the risk in the transmission of infections such as gonorrhea, chlamydia, or trichomoniasis. They reduce the risk for genital ulcer diseases, that's herpes and syphilis, but only when the infected area is covered. And latex condoms may reduce the risk in the case of HPV infection, HPV-associated diseases such as genital warts and cervical cancer. Again, across the board, what you cannot say is that as long as you use a condom, you're going to be okay. Does it reduce your risk? Absolutely, no question about that. But again, the message we're talking about for optimal health behooves us to make sure that we know what medically accurate information we're using when we talk about this. Here's the problem with condoms. People aren't perfect, okay? Again, we know that. That's not a surprise, but people, and many times adolescents, don't use condoms consistently every time, and they don't use them correctly. There's a lot of studies that help to support that. And again, I have listed a few of these here on the slides, but there's a low usage. Okay, again, we can see that the use of condoms has decreased. Adolescent girls were half as likely to use condoms with partners drinking alcohol 2 hours prior to sex. Again, we know very clearly that there is dual concern when it comes to all of these high-risk behaviors that we're talking about. Here's the thing that's so interesting. If you look closely at the Youth Behavior Risk Survey, the group of adolescents that are the least sexually active are 9th graders and 10th graders. Okay, when you pull out that information. Those that are most likely to be sexually active are the juniors, primarily the seniors in high school. When you look at those who are most likely to use condom, it's the freshmen and sophomores. They're the least sexually active, they're the most likely to use condoms. By the time they get to be seniors, very unlikely to use condoms. And I think some of that has to do with the message. When is health class primarily? 8th grade, 9th grade? Okay, is there a repeat of that message anywhere in our high school curriculums? Not very often. And by the time they get to be juniors and seniors, that message is not coming through. Again, this behooves us to begin to look at community saturation types of programs where there's more than one place that they are hearing a message about protecting their health and about having optimal health as adolescents. We have very clear evidence of that as we look at the high school students. We also know that the longer that someone is with their partner, okay, the less likely they are to use a condom. And again, that can be okay if that partner, if both people are not having sex with anybody else. But we also know the percentages, particularly as they get older, of those that have multiple partners. And again, not using it correctly, not understanding how to use it through the entire act of sexual intercourse. And again, there are many studies that look at the difficulty and the problems with that. The other problem with condoms is that they are not equally effective for all of the sexually transmitted infections. And again, that's a whole talk for another time, but this infections that are spread with body fluid contact, the condoms are the most effective for those infections. And again, they're more effective in those that are harder to be spread, okay? So again, that's where we see the HIV, the chlamydia, gonorrhea. Again, body fluid contact. When we get down to the skin-to-skin contact, that's where we see much less success because it's spread through skin-to-skin contact. Again, herpes and syphilis are spread both through fluid and skin contact, so there's a little bit better protection. HPV is only spread through skin contact. It is not in body fluid. And again, the very least protection we get from this infection. Is it any wonder that HPV is our most common sexually transmitted infection? 14 million cases diagnosed every year in our country. So again, significant issue when it comes to this optimal health approach as we're talking about this. So here's our first audience participation question. Okay, and I'm gonna ask you just to type your answer into the chat box, and we're gonna, Marianne's gonna help me by looking at these because I can't see them well on my screen, but I just want you to throw out to me, how many people do you think are infected with an infection, new infection, every day in the United States? Just start throwing out some numbers to me. What are your thoughts about how prevalent infections, sexually transmitted infections are in our country?
So far, we have 24 million, 1 million,
Okay.
300,000, 25,000, 200,000, 250,000, 15 million, 400,000, 250,000, again, 75,000, 1,500,000.
We're all over the board here. There's 55,000 people infected with a new sexually transmitted infection every day in our country. What that comes out to is between 20 and 21 million cases every year in the United States. Okay, we probably more than any other time that I can remember are very tuned to daily infection rates now during this time of COVID, I think. More than anything else, you can talk to people many times, they'll tell you how many people were diagnosed or got infected with COVID over the course of a time. This is a situation that I think helps to put this in perspective, but 55,000 people every day infected with a sexually transmitted infection in our country. And here's the thing that concerns me the most, because this is a group of people that I work with. Okay? More than 50% of these new cases are diagnosed in adolescents between the ages of 15 and 24. So this group of people make up about 25% of the sexually active population in our country, but account for more than 50% of the infections. We have to do a better job of looking at optimal health and not just pregnancy prevention when we are having our conversations with adolescents. And we have the opportunity, we're funded to do that, and I think it's incredibly important that we make that, start to have those conversations in a more meaningful way. Now, I'm going to go back to where we started, okay? The public health problem, teen pregnancy, sexually transmitted infections, risk factor, unprotected sexual activity, okay? We've determined that that really isn't the risk factor we need to focus on, right? So when we're talking about an optimal health approach, okay, how are we going to get to no risk? What risk factor are we going to need to talk about when we look at this? Okay. In order to get to a no-risk situation, the risk factor we need to address is sexual activity. Now, how does that really play out? The message that comes through in many of your curricula as you are doing SRAE education is that you look at this group of kids, they have not started having sex yet, and the message to them is to delay sexual activity. And that the time and the safest, this is what the CDC also says, it's directly from their website, the only way to prevent a pregnancy or sexually transmitted infection is not to have sex, or when you do, to be in a long-term mutually monogamous relationship with an uninfected partner. Now that is a mouthful. And typically when I'm teaching this to adolescents, I will say to them, okay, in our culture, that long phrase, what does that typically mean? And 100% of the time, the adolescents will say back to me, marriage. Okay, understanding that not everybody is in that situation. Understanding it doesn't fit for every single person you're talking to. But culturally, in a population-wide message, a long-term mutually monogamous relationship with an uninfected partner says marriage to the kids that we're talking to. Now, let's break that down a little bit further. that needs to be the population-wide primary message as you're talking to people, to say, if you want to be completely risk-free, this is the way to get there. Now, again, I can see all of you, not, but I can tell that the thought is, you know, that's great, but most of the people we talk to aren't there. Okay, well, let's go through those. What about if they've already had sex? Okay, this is the risk factor, identification, sexual activity. Can we get them to a no-risk place? What are your thoughts? Type in the chat box for me. How do we get them to this no-risk place? What would be the message for them to try to get them to that place wherever they are on this map?
Everyone is still thinking.
I know, maybe that's harder to type in.
Share the realistic cessation plan that we have. You can
rephrase the question.
And stop.
Okay.
All right. A U-turn. It's never too late to make a different choice. Someone says glamorize marriage, success sequence for motivation. Help them see the benefits of waiting. Peer support, consistency with awareness. Secondary virginity.
I think one of the critical messages that sometimes is missing here is that, and I saw somebody, I think, type this in, but just because you have started with an unhealthy behavior does not mean you have to continue that behavior. And it's very critical to understand that. And sex in and of itself, in the right place, in the right time, is a healthy behavior. Please do not misunderstand me. I am not saying that sex is not a healthy behavior. Okay. However, there are places that make it much more healthy than others, and situations that make it much more healthy than others. And we are talking to adolescents here, particularly most of the time, very young adolescents. And so again, this is the point where they are at a point of trying to make a decision. So that's where this piece comes in when you talk about putting optimal health in action here. The idea around this is that, again, you have the whole aspect of having a conversation to make sure that the physical things are healthy, right? And then you've got your emotional health, and then you've got your social health, and you've got the mental, emotional, spiritual health surrounding all of that, that it's a whole piece.
Okay, and let's see, we do have about
most likely to make a change if you're in contemplation to action. I found personally in my clinical practice that people were the most likely to make a change if they've had a pregnancy scare or they've been diagnosed with an STD. At that point, they're really ready to have a conversation because they thought that what they were doing was fine. They said, if I used a condom, I'd be okay. I am not okay. Those kinds of things.
Okay, and we have 2 minutes left, and I'll just give you this last question. It says, are there any resources to aid in facilitating conversations about optimal health with other influential and professional adults, like parents, counselors, coaches, or medical providers?
Yes, absolutely.